All right, so I'm going to start now. Can you all hear me, co-faculty?
Yeah.
Well, yeah. Okay, lovely. So I'd like to welcome everyone joining in, all residents across Europe, to the first episode of IJC, which is a new online ESCRS journal club, where we aim to discuss the latest research on cataract refractive surgery with an expert panel, really with two main aims. The first is to refine your practice in cataract surgery, the latest evidence and the latest papers. And two, to refine your knowledge of research methods. Of course, you all want to write papers and do audits, so it will help with that too. So firstly, I'd like to introduce myself. My name's Imran Yusuf. I'm a resident ophthalmologist based in Oxford. I'm also a PhD student. And I'd also like to welcome Basak Bostanci, who's an associate professor at Okan University in Istanbul, who's also one of the ESCRS Young Ophthalmologists with myself. And we're very lucky to have two distinguished faculty here. So we have Professor Sathish Srinivasan, who's in sunny Ayrshire there. You can see him. He's a consultant ophthalmologist and also the president-elect for the UK and Ireland Cataract Refractive Society. And is also the associate editor for JCRS. So it's one of his articles we're going to be looking at today. And also we have Professor Boris Malyugin, Professor of Ophthalmology. He's also a Deputy Director General for the Fedorov Eye State Institution and also the President of the Russian Ophthalmological Society. And of course, you've all heard his name because he uses ring all the time. So I'm just going to start with quick housekeeping. So this is the particular paper we will discuss. And of course, I've just introduced the faculty. We're going to have everyone on mute throughout the presentation just to avoid any background noise. But we want it to be very interactive, so if you have any questions at all, click the Q&A button and you can post questions and comments, and we will try as best as we can to ask as many of them to our faculty as we can. And of course, this will be recorded, so it's available on the ESCRS Facebook page and also on the YouTube channel. So I'd like to hand over now to Basak, who's going to be asking you some questions just to get you involved right from the start. So over to you, Basak.
Hi, I'd like to welcome everyone. So we are going to start by running a quick poll before our discussion. We ask you to answer each question. Our first question will be, what is your standard regimen for dilating the pupil before or during cataract surgery? Do you use just topical dilating drops in the preoperative phase? Do you do topical dilating drops plus mydriatic in the irrigation solution? Do you add intracameral mydriatic? Or do you use all of those above? And we are going to see your answers in a while. So, okay. So let's go on to our second question. So what do you use for patients with an undilated pupil this time? Topical dilating drops plus intracameral mydriatic? Or do you do pupil stretching? Do you use pupil expansion devices? Or do you use topical dilating drops plus intracameral mydriatic plus expansion devices? Okay, and our last question. This time we will ask you if you change your dilation regimen in the suspicion of intraoperative floppy iris syndrome. Do you use just topical dilating drops? Do you add intracameral mydriatic? Do you use pupil expansion devices? Or do you use them both, all three of them? Okay, thank you for your answers. We are going to be back to Imran.
Okay, lovely. So I hope that some of you have had a chance to read the paper. For those of you who haven't, don't worry too much. So we're going to just summarize the main findings here. So of course, this was a paper where they assessed resident cataract surgery, comparing two regimes of pupil dilation, where in the first group they used topical drops, of which there were 3. They used an infusion of epinephrine within the irrigation solution and also used intracameral lignocaine. And in the second group, they used 1% tropicamide only for preoperative use. And then they used intracameral phenyl epinephrine with lignocaine as an intracameral injection. And what they wanted to evaluate was the use of pupil expansion devices, the relative cost of the two different regimes, and also the operating times in resident-performed cataract surgery cases. So quite a simple design. It's a retrospective review, mostly based around a point in which there was a change in the regime of pupil dilation. So this flow chart is from the paper, shows the two groups, and mostly because they changed their practice halfway between the two. And you can see what the exclusions are. Of course, it's always important to look at the exclusions. And in the second group, pay particular attention because 17 cases are excluded because one of the residents used 10% phenylephrine. And so just keep in mind what you think about that as we go through the paper. So these were this table shows both the baseline, well, not the baseline characteristics, but the characteristics of the two groups, and also the percentage of a pupil expansion device used between the two groups, and the mean surgical times and the complications. So just going through and giving you a chance to just read some of the figures for those who haven't. You can see there's 267 cases in each group. The demographics seem fairly well matched. There was a history of tamsulosin use in approximately the same proportions in each group. You can see that the PGY stands for postgraduate year. This is how senior the residents were. And you can see there's a slight difference between the groups in terms of that. They haven't compared them directly. You can see that the pupil expansion device use was 83 in the first group and only 36 in the second group. And you can see they've used a statistical test to compare that between the groups. The mean surgical time, just under 25 in the first group, 22.7 in the second, which they found was significant given the number of values they had. And you can also see the complication rate between the two groups. So whilst iris billowing and iris prolapse were more common in group 1, PC rupture was slightly more common in group 2, but wasn't significant because of the low frequency of the complication. So they're the basic findings between the groups. And what they also wanted to do is to do cost analysis, comparing which the two groups as to which was cheaper. And you can see this is their costing. Sort of per case, and you can see the two groups there. I suppose what's glaring about, or what's obvious about this is that the topical phenylephrine use, which is in the first group, is incredibly expensive. You can see it there, $13,000 to use phenylephrine in that first group because they used a bottle which had to be used one per patient. And you can see the costings of the different devices, including the Malyugin ring and the iris hooks. And of course, that was obviously important in what the final cost was in each group. So that's just a brief overview of what they found and what they were looking for. And it's always good to read these boxes because it always tells you at least what the authors think about what they thought was known before and what they think they've added. And obviously, they think they've added the fact that using the second regime with intracameral epinephrine seemed to improve the efficiency of resident-performed cases, decrease the costs, decrease the use of pupil expansion devices and therefore the operating times. So in a nutshell, that's the paper. So with all that thrown at you, please do ask any questions in the Q&A. And I'm going to hand over now to Basak, who's got a couple of questions for our faculty to start us off.
Thank you, Imran. So I would like to ask some general questions. I would like to start with Dr. Srinivasan. Can you tell us about the standard regimen you are using for people with undilated pupil, and do you change it for people with tamsulosin use?
Right, okay. The standard regimen, thanks Basak for the question. The standard regimen for patients with cataract surgery in my university practice is 1% tropicamide and 2.5% phenylephrine. And in addition to that, all patients do get a topical non-steroidal anti-inflammatory as well to prevent any intraoperative meiosis. If the patients are on alpha blockers, my preference in addition to the topical regime would be an intracameral commercially available mixture. So at least in the UK and in Europe, we have access to Midray, which is a combination of phenylephrine, lidocaine, and tropicamide. So that's the combination I use for patients who are on alpha blockers. Intraoperatively, if the patient pupils becomes really small, or in spite of using intracameral mediatrix, if I feel that the dilatation is not adequate, then I would go on to use a pupil expansion device.
Okay. Thank you. So my last second question will be for Professor Malyugin. Professor Malyugin, can you tell us the main advantage of using a ring instead of a hook? And especially in an IFIS case, what is the main advantage of using rings?
I think there are several advantages. First of all, with using any pupil expansion device as opposed to the iris hooks, there is no need to create 4 additional incisions to introduce these hooks. So I think it's a good advantage because with less incisions, there is less risk of possible contamination of the anterior chamber that may happen. So there is a gateway for the infection. The second is that it was being shown in several publications, such as the one from a British group led by Paul Ursel, that pupil expansion device iris ring is taking much less time as opposed to iris hooks. So he made the study comparing the time of the surgery with the hooks and with pupil expansion device, and both in resident's hands and experienced consultant surgeon hands, there was a drop of timing. So that's also quite interesting. And the third, I think that is also important, that with utilizing the pupil expansion device, you're keeping the pupil round. And when the pupil is round and not square, as again we may have in some pupil expansion devices such as hooks, so you have a tendency to less overextend the pupil, to less traumatize the sphincter tissue, which I believe is also very important and helps you to reduce the trauma during the surgery.
Okay, thank you. So again, I will ask you, Professor Srinivasan. So you stated that you're using a licensed intracameral mediatic, but some of us in our countries don't have licensed epinephrine. Can you tell us what is your opinion about using an licensed product intracamerally? And also, I would like to learn your opinions about doing a pupil stretching.
Sure. Coming to the use of non-licensed products intracamerally, I think it depends on the regulatory restrictions which each countries have. So I think it's very difficult to give a unified answer. Certainly in the UK, we are strongly discouraged to be using anything which is unlicensed. A couple of issues here. If you're going to use an unlicensed product, if your local hospital pharmacy can compound it for you, and if they have a compounding license, then it becomes slightly regulated, because the responsibility moves away from the surgeon to the local pharmacy, where some of the hospitals have a compounding license, so the pharmacy can prepare it. In that scenario, there is no risk of having any dilution errors. But my personal view is, if it's left to the surgeon to make these formulations either during the operation or at the beginning of the operation inside the operating theater, just because of the turnover of the staff and the turnover of the residents and the surgeons, there's a very, very high risk of having accidental dilution errors, which can have very detrimental effects inside the eye. So as long as the local pharmacy can do it in a controlled fashion, and they can provide you with pre-made up syringes clearly labeled to be used per patient basis, then I think it dramatically reduces the risk. But certainly using standardized, pre-made, commercially available pharmaceutical products are much better than taking the responsibility of trying to dilute it and make up your own inside the operating theater environment.
Okay. And also your opinions about doing a pupil stretching?
I am not a big fan of pupil stretching. One, because now we have got devices which can give you controlled dilated fascium. if you're using pupil stretching, you can still do it if you don't access to it. One of the risks is to developing multiple uncontrolled sphincter tears, which might be cosmetically not very appealing at the end of the operation. So there's always a risk that you could either overdo it and having unexpected or inadvertent multiple sphincter tears, which might cause correctopia and have cosmetic issues. Certainly with the access to all these devices and also to good intracameral mydriatics, I think my personal preference would be to avoid pupil stretching.
Okay, thank you. Here's my last question to Professor Malyugin. Do you think they stated in their article that in selected cases they are using retrobulbar anesthesia? Do you think this can also contribute to the dilation of the pupil as well?
Basically, I do think that at least in my practice, there is no need for retrobulbar anesthesia as far as you inject intracameral lidocaine, because when you're dealing with the pupil, which is not very well dilated, so there is still a risk of that you touch the iris and that may cause some unwanted sensation. I'm not even mentioning that if you implant the pupil expansion device that may, and you need to touch the iris, so you generate this sensation. So if you don't use this intracameral injection of lidocaine in small pupil cases, you might consider using peribulbar or retrobulbar anesthesia, which is most probably not needed in the majority of cases, of the regular cases. In these particular settings, I don't know, maybe what was the reason for this relatively high number of peribulbar anesthesia. Maybe it is kind of, anxiety disorders, or some patients were not very calm at the very beginning, or there were some combined surgeries when the sacral may be combined with some other procedures. So that's it's a little bit higher than usual, although I understand that this was a surgery made by trainees, so that maybe the reason is that the trainee surgeon may be a little bit more relaxed when they are dealing with the patient who is having retrobulbar anesthesia and the patient having less sensations when the surgery is prolonged. So that may be the reason why that anesthesia, with type of anesthesia was selected.
Okay, thank you. Imran, do you want to continue?
Yeah, sure. I just want to encourage the audience to ask questions. There are 63 of you, so please do ask questions. You have a captive expert faculty, so take your chances. I just wanted to ask Sathish, you did bring up about compounding pharmacies, and that's obviously an important part of this paper, because in the second group, they asked the local pharmacy to prepare the intracameral epinephrine and dilute it. And of course, they didn't account for that in their costings. And of course, when you compound a drug, clearly there are costs associated with that. So I just wonder whether, in particular, do you think what they state about the cost of phenylephrine, obviously that was a huge factor in the difference in the cost of the two dilation regimes. Clearly it will vary depending on the region. For example, in your region, would it cost that much to use phenylephrine for dilation?
The short answer is no. The long answer is pharmaceutical companies, the costs of drugs in the US are much higher compared to the rest of the world. And at least in Europe, certainly in the UK, as you know, Imran, you have got access to this minims or single-use applications of most of the dilating drops. So I think the cost in Europe settings would be significantly less compared to what the costing in the US is. But having said that, whichever part of the world you're going to compare, the pupil expansion devices are always going to come out more expensive than dilating drops. That's an answer we all knew before the start of the study. But the cost differential or the cost difference would be much more variable in different parts of the world depending on what the prices of the drugs are. But always need to be mindful, any of the drugs, either mydriatics or antibiotics or even the anti-VEGF, are far more expensive in the US compared to the rest of the world.
Yeah, I'm glad you said that, Sathish. I did a bit of digging. So just for an example, in the UK, the minims we use, which are single use, £11.87 for a box of 20. So therefore, for 267 patients, that would cost £158. And of course, in this American study, that cost $13,000. So I just wanted to illustrate the point that you made. Professor Malyugin, I have a question for you. We saw in this design of the study that 17 cases in the second group were omitted because the resident used 10% phenylephrine. Do you think that skews the data? Do you think that would have an influence on the risk characteristics of the groups or of any of the outcome measures that they present?
I think that the increased amount of percentage of phenylephrine may decrease the chance of intraoperative floppy iris syndrome. And as we see from that study, the majority of these patients were men, which is not surprising because it is a veteran hospital and we expect the men to be there. And the very high percentage of this population was using tamsulosin, and that's why there was a high risk of intraoperative floppy iris syndrome and smaller pupil and so forth and so forth. And we know that in patients with intraoperative floppy iris syndrome, when we adding to the preoperative medication protocol atropine and non-steroidal anti-inflammatory drugs, that significantly reduced the chance of ISIS. So that was not being used in that study. So, and I expect that there could be some slight changes in intraoperative medication protocols that may change the results with respect to the need for intracameral injection of mydriatics or the need of pupil expansion device, like in that study.
Yeah, you make a very good point, Professor Malyugin. Of course, this study was based in a veteran centre, and a veteran is more likely to be an older male, at least in the current world. So you're right, that might explain why there was such a high rate. Sathish, drawing on your experience as editor of the JCRS, just for those residents who write papers and are involved in research, I just wanted to ask, because they applied a student's t-test to their data, and of course, the assumption there is that the data is normally distributed. However, they didn't specify whether they did a test of test normality, which is of course what statisticians often do, is test the data set to see whether it's normal before then applying the correct test. So as editor of JCRS, would you suggest that we do that with our data sets, or can it be assumed that the data is normal?
No, I think you bring up a very, very fair point, Imran. You can't assume statistics. That's one of the main fundamental flaws. One of the fundamental flaws of the study was assuming normality, and the statistical test was not good. The other fundamental weakness in the study was there is no clear criteria on when to use PED. They haven't specified at what pupil size they decided to use PEDs, which means it's a very subjective variation. And once again, we don't know from the methods and materials that call, who made that call, whether it was the supervising attending or whether it was the resident. I think that was a glaring disadvantage of this paper, if I have to really be critical of this paper, was there is no clear, that's one of the disadvantages of a retrospective study. All they did was just go back and looked at which patients had rings and which patients didn't have rings. But it's not clearly specified. If it was a prospective study, then you would have set up clear criteria on the pupil size or other features which makes you decide whether you want to use a PED or not. So given the fact that that was subjectively left open, it is very unclear whether that decision, one, was taken by the operating resident or whether that decision was taken by the supervising consultant sitting next to the resident. So I think that brings up a big variability in the inclusion criteria. And second thing is about the statistics and the use of the t-test. So I think if I have to put on my editorial hat and critique this paper, I think those are the two big things I would have picked it up.
Yeah, well, I'm glad you said that, Professor Srinivasan, rather than myself, being the editor, one of these associate editors of JCRS. And of course, a retrospective study generally, of course, you have less control over confounding variables. And as we know with our A constant, when we select our lenses, that really accounts for everything else that we don't know. And of course, in this study, there are probably many other variables that we weren't sure of. Like, for example, if there was a very slow surgeon in the group 1, then that would have skewed the results in favor of group 2, for example. So I'm glad you brought that up. I guess one final question for Professor Malyugin. I don't know whether you have experience of these, but in the UK anyway, there's one company which manufactures a Fornicil pellet, which is used preoperatively for pupil dilation. It has a cocktail of dilating drugs within it, and then it's removed before surgery. And I have done a few cases where this has been used, and it seemed fairly obvious to me these pupils were obviously much more dilated than our usual regime of drops, because I'm not really sure with our nurses how many drops patients actually get. They don't seem very well dilated on the whole with drops. I just wonder whether the use of pellets might improve dilation, whether you have any experience of that. I understand it will depending on the region.
Imran, no, unfortunately, I don't have this experience with the pellets. However, I think we are in the era of the new epidemic and in the COVID, and we know that the extending the preoperative protocols and medications might not be the best idea. So we want in that era to decrease the contact in between the people and the staff and the patient, to make them all safe. So the sooner we do the surgery, the quicker we do the surgery, and the easier or quicker we will release the patient from the operating room is the best approach. So by reducing the time needed for intraoperative or preoperative dilation protocol, we may save quite a significant amount of time that will help us to avoid the need for the patient to stay in the hospital. So I think anything that will move and drive us in that direction might be very helpful and very useful, not in the regular setting, but in the current setting of when we're thinking about how to optimize our patient flow, how to adjust our patient flow to the new reality of what we are all having now. So, and I think that might be a good option. I was using intraoperative mydriatic since I was a resident, and I started my residency 32 years ago. And when I entered the clinic, so it was routinely used in the clinical practice, intracameral injection of phenylephrine in all patients. So, and since that, so that's becoming a routine procedure for me. So I'm using the phenylephrine intracameral injection in all my surgeries for more than 30 years. So, and I'm happy with that. So I'm glad it's coming now to the level of, wide acceptance of that technology with different commercially available drugs. It's still off-label in Russia. It used to be off-label 30 years ago, and it's still off-label, but we're still using that solution, which is a little bit stupid, but that's the fact that happens. So, and I think it's the way to go. Intracameral injection is the way to go.
I mean, I do know surgeons in the UK who do that, and I think you only have to have 1 or 2 patients who dilate hugely with intracameral mydriatics for you to not trust whoever it is who puts in the drops beforehand. So I do know consultants who give, as you do, Professor Malyugin, intracameral dilation to everybody because they know that they may not have got the required number of drops beforehand. So thank you for that. We're going to take a couple of questions from the floor just before we finish. I'll address one from Vasilios, who asked, is the pellet costly? Sadly, Vasilios, I don't have that information to hand. I suspect in the UK it's probably more costly than the drops. Otherwise, everyone would be using it. So sorry, I don't have a direct answer for you, but I'll try and find out and tell you at the next ESCRS meeting. Basak, do you want to take some of the questions from the floor?
Yeah, we have multiple remarks, but I would like to direct the questions first. So Dr. Artemis is asking our panel's experience about using Malyugin rings versus hooks in cases with shallow anterior chambers. Can we start by Dr. Malyugin?
You know, it's of course when the chamber is shallow, you have to be quite cautious in introducing the rings because you simply have less space to manipulate. However, by using highly viscous ophthalmic viscosurgical devices, in most of these cases, you can significantly deepen the chamber and have enough space to manipulate. In the very rare setting, which is really very rare, so you even with the injection of these highly viscous OVD like Hilon 5 or similar, you are not being able to expand the anterior chamber depth. So in that case, I do think that iris hooks might be a good option to consider, as you have less manipulations within the anterior chamber by introducing and removing. And most of the manipulations are made extraocularly, and that's a benefit for that technique.
And another question would be, besides Hilon 5, do you have any preference for using any other viscoelastics in such cases?
So my personal preference, I always use two viscoelastics. I start with dispersive and then switch to cohesive. And basically utilizing dispersive viscoelastic at the very beginning of the case and doing capsulorhexis even under the dispersive, not kind of a classical soft shell technique that was described many years ago. I found it quite easy to go in 99% of my cases.
Imran, do you have more questions?
Just one more, I think, and I'll address this one to you, Sathish. I've got a question about if commercially available intracameral dilation agent isn't available, what concentration of phenylephrine would you use intracamerally for a small pupil or IFIS case?
Once again, I haven't used any off-label one, but if you want to use one, the best thing would be the Minims intracameral, the Minims phenylephrine, which we use topically, which is preservative-free. All you need to make sure that whatever you're using is preservative-free and is also bisulfite-free, so that it's not toxic to the corneal endothelium. There are several papers both on epinephrine as well as the epi-sugarcane concentrations, which have been widely published and used quite commonly among the US surgeons because they don't have a commercially available intracameral mydriatic at the moment. So if you refer to the literature both on either intracameral epinephrine or intracameral epi-sugarcane, you'll be able to find out what concentrations you want. If you want to use phenylephrine, the easiest and the safest would be to use the Minims one, which we have available in the UK, and I'm sure it's available in Asia as well.
Yeah, and just a following question from that, Sathish, just because we're on the subject, is there any study showing the effect on the corneal endothelium of intracameral phenylephrine or intracameral epinephrine?
Intracameral epinephrine has been widely used. As Boris said, it has been used in the US for over 25, 30 years. As long as it's bisulfite free, to my knowledge, there was one commercial company which was making it bisulfite free, but that company has stopped production. So you just need to make sure that whatever you're using is completely preservative free, most important bisulfite free, so that it's non-toxic to the corneal endothelium.
Okay, thank you very much. I think we've probably run out of time in terms of questions from the audience, but we do thank all the participants for their questions. I'm just going to go back to the slide. I've just got a couple of things to add there at the end. In fact, before we go any further, Basak's got a couple of questions to ask all of you. We want to know whether this has changed your practice or whether it will change your practice. So we'll go over to the poll.
Yeah, we are asking you if this discussion makes you change your practice. And then we are going to ask how. Okay, nice.
Yeah, you're obviously convinced by that. That's good. And now we're going to...
Yeah, we're going to have the second one. We're going to this time ask you, what would you use now for patients with an undilated pupil? Well, it is approximately near, but topical dilating drops plus pupil expansion devices plus intracameral mydriatic is more now. Thank you for answering our questions.
Yeah, that's a big swing. We've gone from 13% who'd use all of the devices to 64%. So we've got a very convincing faculty here. So that is a very large swing. Gosh, you two are very powerful people. So there we go. I just wanted to finish by thanking all of you for joining us, but in particular for thanking our faculty, Professor Srinivasan and Professor Boris Malyugin. It's been wonderful having you on the first episode of IJC. Thank you for all your expertise and wisdom, and clearly it's had the correct effect on the audience. So thank you for joining us for this first IJC. There'll be a recording of this available in 24 hours on the ESCRS YouTube channel, and there's some questions. If you have any questions, you can direct them this way. Before we go, we just want to tell you about the next episode of IJC. We all hope you've learned something. Clearly, it's practice changing for all of you. So anyway, we hope that you'd join us for the next one. I'll hand over to Basak just to summarize the next IJC.
Thank you, Imran. So we would like you to save the date. Our next episode will be on 5th of August, and we are going to have, again, a wonderful faculty. We are going to be with Professor Conan, and we are going to be with Dr. Adi Abulafia, and we are going to be discussing the risk of posterior capsular rupture during phaco in eyes with injections. Thank you.